Thank you very much. Very honorable chairs and members and guests here. It's incredible honor and pleasure to be here, specifically as this friendship is growing and the incredible work that has been done here by many of the colleagues, specifically Jeremy and the group also in prostate cancer, and as well Dingwei. We've been working together for some time, and I'm very happy to be here and actually discuss some of the concept that I'm not that well known of, but I'm very much interested in, is the management of local therapy for metastatic disease, be it in bladder cancer, in other diseases, in oligometastatic, in the definition of that, and specifically in prostate cancer, where we are, I think, ahead of the curve compared to other diseases. These are my disclosures. None of them will really affect my talk, but certainly they influence the way I think and what I'm doing every day. And I'm involved in many clinical trials in this space, in the metastatic space of hormone-sensitive prostate cancer. As you know, and you're going to hear later on, is the field of prostate cancer, metastatic hormone-sensitive prostate cancer, is rapidly changing. It has been a lot of progress, from dual therapies, being with docetaxel, now with NHDs, and now with triple therapy. And we're trying to find our voice, what is the optimal therapy for each individual patient to deliver really that precision medicine that you're hoping to achieve for the patient, that is the right therapy for the right tumor in the right patient at the right time. And in this question, there's been always, what is the role of the local therapy? And that is specifically because we always have seen that patients who have disease progression after local therapy have a much better natural history compared to those that have a de novo disease, and that's one part of the risk stratification we have for our triple therapy concept. So how does local therapy do? Should we do it? And what is the impact? So this is really the field that is changing, and I want to just say, there's really been very little effort in these large multi-center trials to look at the effect of local therapy. The STAMPEDE and the PEACE-1 have addressed that, and I will go into the data a little bit integrated in the drug trials, but we need to certainly do more. This one is sort of for Max. I added that yesterday night. It's, the concept of metastatic progression, it is a concept that is evolving over time, and understanding the biology underlying the metastatic progression and how that interacts with the rest of the body, the tumor microenvironment, the body microenvironment, is very important. As Halstead, pondered that you have the local progression in a very organized stepwise fashion, and that's how metastatic progression happens. That is also all the basis for his surgical interventions and how he approached the disease. Now, this, another group from Johns Hopkins actually looked at this and recently and said, well, that's not really like that. Stephen Bova and his group really looked and found that metastatic progression is really a polyclonal effect, and even the metastasis can make baby metastasis that can uniclonal, polyclonal, and they interact also with the primary and so on. So there's much more complex than what we thought. And certainly in the breast cancer literature, it has been known for a long time that the circulating tumor cells will have a crosstalk with the primary and the metastatic sites, and can reinvigorate and reinfiltrate the primary and create some new activities and progression. So, people have looked at it and said, what could be the benefits of treating the primary? One, you could lower the number of circulating tumor cells, the number of clones. Number two, you disseminate cells, the cytokines, the chemokines. You're going to have less tumor-shed RNAs, microRNAs. Your local angiogenesis will be decreased, and thereby also your resistance mechanism in this very polyclonal, very heterogeneous primary tumor can be decreased, and so on. So there could be some benefits to that by treating the primary and not only the metastasis. Again, another group from Johns Hopkins has looked at it in a very smart way in 2011, already shown that if you treat the patients with metastatic disease with ADT and docetaxel, what at that time was already super maximal treatment with 1 year of ADT, you're still going to have over 94% of the patients having in the primary tumors that subside, despite sometimes the metastasis not being adequately treated, and you already have a mechanism of activation of intratumoral steroidogenesis and so on happening, so the resistance mechanisms are setting in. So that could be a good also rationale for it. So I'm going to talk about radiotherapy very briefly because it's going to set up the stage, cytoreductive, and then how the two compare. So the radiotherapy, the literature, for many years we looked at the literature based on population-based data where there was a huge selection bias who gets radical prostatectomy or radiation therapy to the primary in a metastatic setting. So this data is kind of giving some concepts and some ideas, but it's certainly not strengthening. But the data was pretty, compelling that if you give radiotherapy to the primary, you're going to have here better outcomes, survival outcomes even. So that set up even a very nice study here that showed that this is not only that you get even radiotherapy, but it's going to be also dependent on your tumor burden, your metastatic load. That's going to be of importance to see the benefit of treating the primary. So there's 3 randomized controlled trials where they looked at radiotherapy in this setting, and very important, the STAMPEDE trial looked in the overall population, the STAMPEDE multiple trials, and Parker reported that and said, well, there is no benefit of radiotherapy to the primary if you treat metastatic disease compared to standard of care, which is, evolving field. Nevertheless, if you look at those based on a chartered criteria of low volume disease, and I would almost argue that the low volume and high volume disease really doesn't matter in the management of metastatic hormone sensitive. This is something that is only misguiding, but it only has one benefit: to choose the patients for local therapy. That's the only benefit, not for the systemic therapy, but for the local therapy. And they found that actually those that have low volume metastatic disease, they may have a benefit of radiotherapy to the primary. A second trial, the HORAT trial, was unfortunately underpowered with 432 patients, did not find those results, but it was going toward that direction, and sort of a meta-analysis showed a benefit. Nevertheless, the benefit is 8% at 3 years of survival benefit. So it's not a large benefit, but it's a tangible benefit. This has changed the guidelines, right? Since then, since 2019, in the guidelines, if you have low volume metastatic disease based on a chartered Chris Sweeney definition, you were in the NCCN, EAU, no matter what guidelines, you should offer, discuss, and offer the patients radiation to the primary. Now, recently at the ASCO, you had Alberto Bossi answer this question integrated in a PEACE-1 trial. The PEACE-1 trial is a very complex trial to understand, trying to answer multiple questions with multiple arms, and often underpowered to answer those, and some conflicts in the data, specifically as the standard of care has changed over time. It used to be ADT, then it's ADT, docetaxel were allowed, and then you needed to have ADT, docetaxel in the control arm. But certainly, there's 2 arms that had radiotherapy in there, and either in combination or without combination. And this is the data, what we see from there. The data is pretty confusing, I would say, that if you had standard of care, which would be ADT or ADT docetaxel with abiraterone, you add radiation therapy, you have a benefit. But if you don't have abiraterone in the arm, you may not have any effect. So it's, if you look at it in OS in the low volume group, that was in the low volume group, the OS had no difference in there, so it's only on some endpoints. But what he concluded is that your local event rate is decreased, so you have less local events. And that is, for him, the definition, I will show that you need less interventions for local progression or local symptoms. But if you look at the data in detail, actually, it's something for us urologists is not a big issue, is number of TURs you need in these patients. Who cares about that, right? So I think this is the basis of his data. So I think his conclusion he made there, and I'm very close friends with him, I don't agree with them. First of all, the trial was not designed to answer the question he tried to answer and sold us. It's only subgroup analysis. It was not powered. We don't really know the effect of docetaxel. The discordant results with the STAMPEDE and the grade 1 and grade 2 adverse events are also of importance. And therefore, I think today one can say, for the radiation point of view, there seems to be a synergism if you add radiation therapy to NHD and ADT. Absolutely, there is some activity there, but I do, and it's in low volume patients you should do it. I certainly offered in patients where I think this could be, you could get that deep remission that, almost could get to that cure. You're treating the metastasis, even metastasis-directed therapy. That's a whole discussion in itself, if it works or not. You're delaying systemic therapy burden. In those patients, certainly we should use it, but we should not use it, as he concluded, routinely in patients to avoid local disease progression or symptoms. So what is the role of cytoreductive radical prostatectomy in this setting? So the radiation therapy data is pretty solid. What about their surgery? Surgical data is very poor quality, retrospective mostly, except one study that is well done. But it all is showing in the same direction. If you look at it in Munich registry, we don't know how the selection happened, but you know, those that had local therapy with surgery did better than those that didn't in metastatic disease. Heidenreich, in a prospective study with the control arm not really being adequate, showed us a lot of important things that has changed my practice. He showed, well, he said, look, the continence rates are worse than standard radical prostatectomy. Let's be honest with it. Whoever thinks that's going to be the same, it's not going to be the truth. But we can pre-select the patients based on neoadjuvant ADT, and that has changed my practice. Certainly, I've started doing that. And your local progression rate or your local event rate is going to be the endpoint of interest, not overall survival, but that's going to be important. And the metastatic volume, similar to the radiation therapy data, may matter to select the right patient. Now, Prasanna Suryakumaran has looked at the same, shown the same concept, as well as the group from the Martini Clinic, that the local complications are probably the endpoint to look at. But this is not strong evidence for the surgery for many reasons. The control arms, you know, these are all the trials, were not ADT and HT, and no matter how you look at it, they are underpowered, retrospective to a certain degree, and the designs were not optimal. Now, there is one very good trial, and honor to here to Ding Wei for leading that trial from China at his Fudan institution. He looked at it at 200 patients where the control arm was ADT and the treatment arm was local radical therapy. Most of the patients received radical prostatectomy. And he looked at it and he found wonderful results. We know that surgical margin and so on may not matter. That's not the endpoint we're interested in. But incredible 66% of the patients had a PSA 0 after that intervention. And you had improved outcomes of radiation progression-free survival, which is an adequate endpoint, I think, a surrogate endpoint for OS, but also OS data, even early on, incredible results. A lot to be learned from this trial, and we're going to continue watching this trial as the data evolve and become more mature. Prasanna in the trombone trial looked at something like that, and he found as well that it's safe and feasible in his first step of the trial before he opens up to more inclusion. But he found even higher PSA 0 at 6 months, which is important. The nadir at 6 months will be an important point. We know already in the metastatic setting, this has been shown by Susan Halabi and many other people, Laurie Klotz already showed, and now all the clinical trials, your PSA response, the depth of the PSA response is a good surrogate for long-term response, long-term benefit. Now, there's another trial that prospective trial I want to talk to you about. This is a non-randomized observation patient preference trial. So the patient chooses in which arm he goes. But that trial, you can look at it and you cannot make a lot of questions. You can answer to that. But what you could see in the initial analysis is that the cytoreductive radical prostatectomy had some effect on outcomes, but number two, that it seems to perform better than radiation in this set of patients with the local progression, local GU events. So what is the price of a local surgery? It is not insignificant. It's pretty significant complications that will happen. Whoever says it's not like that probably has never done this. Maybe in the oligometastatic setting, you will have better results, but certainly in those that have local aggressive disease, you will have a little bit more adverse events. Specifically in the continence rates, you're not going to perform as well. So the final questions I will try to answer. What should be the thing, radiotherapy or cytoreductive prostatectomy? Well, again here, I showed you the LUMP trial, which, you know, doesn't address it because it was patient preference. There was a selection bias, certainly. What about the retrospective data here, the SEER Medicare? I want to show you how flawed population-based data sets can be. Indy Gill looked at it with the patients up to 2009. No difference between IMRT and radical prostatectomy. We looked at the same data with a little bit more follow-up, 4 years longer, and we found radical prostatectomy to be better than radiation therapy. But the reality is, I don't believe there's a difference between the two if adequate radiation dose is given when it comes to overall survival benefit. What is clear is that the lower the tumor burden, the metastatic burden, and the patient performance, the better the results in both groups. But where the radical prostatectomy may outperform radiation therapy is the local complication prevention. And that can be looked at in the LUMP trial, again, 2 different analyses, but also other studies have looked at, obviously it makes sense. If you take it out, you're gonna have less local progression and all the problems we know from from local problems. As we're managing the metastasis better with our triple therapies, double therapies, and sequential therapies, the local issues will become more important. So therefore, I think the primary endpoints in this question should be prevention of side effects of local disease and lowering the tumor the therapeutic burden. These should be the endpoints in a trial and not overall survival and radiographic progression-free survival. Prediction is going to be important to identify the patients based on genetic status and many other factors. Another area that Giorgio and many people are working on in oligometastatic, the definition, what is low volume, what is oligometastatic, is going to be essential in this field. The imaging standardization is going to be essential to identify the patients that should be included. The PSMA PET will be one of the criteria to better characterize the tumor burden. And this is just the last publication that Giorgio and Pavel, one of our fellows, have looked at together and looked in the oligometastatic setting, what is the role of cytoreductive prostatectomy? Well, it does okay, but not that great. Patients will still progress, but what is important, we learn about which factors may help us identify the patients who have the largest benefit from a local therapy, aggressive local therapy. And that is certainly the metastatic burden, but also the nadir you get after the primary therapy, and maybe was underpowered, if you get neoadjuvant therapy, you respond, the metastatic distant side respond, then it's worthwhile to go after the primary. So sort of a litmus test that we have seen in other diseases happen. But we will see if that becomes true. Please get involved in this oligomet registry. Giorgio is here, maybe you can talk to him, and we're happy to have many people involved. So conclusions. I think treatment of the primary is a valid option, and I think a recommended option, low volume metastatic hormone sensitive for local disease control as an endpoint. I think selection is going to be essential in the future, imaging biomarkers, but I think also treating the metastasis in a litmus test, and if they respond, then treating the primary makes more sense than just treating everybody in the primary. I think radiotherapy to the primary is the standard for low volume, but the radiation dose needs to be adequate. So if you come with 62 grays, forget about it, that's homeopathic doses. And maybe we can capitalize on this effect with the NHT, the synergism, how to enact with it. I think cytoreductive prostatectomy should be part of clinical trials, like Dingwei has done it, very interesting, and we should put our efforts in it. And I think the future probably is going to be some form of ablative technologies, but that triggering a systemic effect, immune effect, and using that to get even more mileage with other therapeutic concepts. Thank you very much.